So thanks a lot for your very kind introduction. You are you are really a very close friend of mine. So that's why you had this very kind word for me. It's a pleasure to be here with you. I'm going to share my screen and have a chat on the how and when it's useful to create an ASD in patients with the congenital heart disease. And in particular by using this very clever device, which is the atrial flow regulator. The history of atrial septal opening is quite old in congenital heart disease, and it dates back to the creation of ASD without thoracotomy by Rashkind in the old times. So we have a long, we have a lot of experience about that. And since then, several devices has been developed, mostly in the last few years, about the creation of an atrial septal defect that looks like to be useful even in adults without congenital heart disease. In particular, the Occlutech Arterial flow regulator is a gold-coated needle wires. It's quite usual, similar to other devices for ASD closure, but it has a hole in it, which can be of different size from 4 to 10 millimeters, and it goes through a 8 to 14 French sheet with a flexible connection. Indications for the use of atrial flow regulator in adults with congenital heart disease are left atrial decompression in diastolic or systolic heart failure on the left side, right atrial decongestion in patients with pulmonary hypertension, and similar concepts may be useful in congenital heart disease. I would add that we do usually open atrial septal defect in patients under circulatory support when there is a failure of the left ventricle, and so decompressing left heart is not unusual in our practice. This is probably one of the first report about the useful use of atrial flow regulator in a patient with irreversible pulmonary artery hypertension with significant dramatic improvement of the hemodynamic and symptoms for soon after the procedure. This is one of the first report of case series on 12 patients, adults with pulmonary hypertension with significant increase of cardiac index, systemic oxygen transport, 6-minute walking test, and the follow-up ranging up to almost 1 year. All devices had a fenestration well open. Regarding atrial flow regulation, the compression of left heart, it is well known that opening it has been demonstrated that opening reduces congestion symptoms, improves quality of life, NHA functional class, because of the reduction of left atrial pressure and hemodynamics. And the positive results are obtained in both systolic and diastolic heart failure. There are some evidence supporting the role of interatrial septal shunt creation in symptomatic patients with chronic heart failure, and it comes from the Lutembacher syndrome, mitral valve stenosis and atrial septal defect. These patients had much fewer symptoms compared to patients with mitral stenosis and intact septum, and also animal studies. The increase of LA pressure in heart failure causes symptoms and decreases survival. This is well known, and in particular, elevated left atrial pressure related to, as demonstrated by a wedge pressure more than 25, is a finding of very low or very poor prognosis. This is a large trial by using atrial flow regulator in patients with both systolic or diastolic heart failure, more than 100 patients followed up for 1 year. and and those patients had all the fenestration always open at the latest follow-up at 1 year, with significant improvement of pulmonary capillary wedge pressure, and in particular of symptoms, with almost 2/3 of the patients that moved from any functional class 3 or 4 to functional class 1 or 2 at 1 year, with no impact on mortality. These are the conclusions about the pre-lead trial. So a lot of, some evidence, not a lot, but some encouraging evidence in the use of atrial flow regulator in different clinical scenarios. What about congenital heart disease? Data are more scarce about in our field. This is the largest trial, or not trial, registry, let's say, on multi-institutional US experience of the Occlutech ARF device in congenital and acquired heart disease. So a total of 15 patients, 6 pediatric and 9 adults. And as you can see, there were 5 out of 6 Fontan patients in the pediatric group, 1 left atrial hypertension, while in the adult group, there were 2 left atrial hypertension, 3 congenital heart disease with pulmonary hypertension, and 4 idiopathic pulmonary hypertension. Not all patients had a pre-procedural shunt present in the adult population. These are tables difficult to read, actually, sorry about that, but finally showing that all patients had a significant improvement compared to the basal condition. This is an interesting case report, because a part of this series, there are mostly case reports of very small case series in congenital heart disease. And this is an interesting case from Evelina Hospital about an 8-year-old failing Fontan patient, where acutely, because of very bad clinical condition, a stent was used to fenestrate the Fontan, but early after, a couple of days after a stent implant, a thrombosis occurred. And again, under critical condition, a AFR device was implanted by performing a transeptal approach from the right jugular vein directly into the left atrium with a quite bad, perfectly patent AFR device. And the patient that was discharged at home with a oxygen saturation, systemic oxygen saturation of 77%. So a bit low, but patient alive. What about the procedure itself? And then I will come to our experience in Rome. The procedure consists in the creation or in performing a transeptal puncture if there is not a baseline, a shunt at baseline. This is standard transeptal puncture. Then after some transeptal puncture, the septum is prepared by using a high pressure balloon. They should be 2 to 4 millimeters larger than the AFR fenestration we would like to obtain. And the balloon must be held in place and inflated until the septum is completely dilated. So no more wasting on fluoroscopy. And then the device is implanted. The technique is perfectly the same as when we implant a standard ASD Occlutech device. And the device is implanted through a 8 to 214 French introducer according to the size of the device. Obviously, everything is performed under TE control, and the device is released, and the shunt is checked at TOE. Patients must be taken under anticoagulation and all life, or just for 6 months, and then aspirin or double antiaggregation according to the baseline disease. What about our experience in Rome? I've been working in Rome 1 year ago, and we had a total of 3 patients during this time. This is plus a 4 patient I will going to speak about, which is very interesting. This is a 16-year-old girl with a complex congenital heart disease with hypoplastic mitral valve and intact interarterial septum and large VSD. So this patient came late to our attention because of social conditions and coming because of being immigrant. And so she had already pulmonary hypertension, which was both precapillary and postcapillary, and with a quite poor, very poor clinical condition, functional class 4. So you see, these are some videos. You can, I'm gonna run this. This is a pulmonography with a flow coming back to the left atrium and no flow from the left atrium to the right atrium. And then transeptal puncture was performed, and the left atrium was reached. You can see how big is the left atrium with a minimal flow through the mitral valve. Then the high pressure balloon passed through the septum, so a quite tight waist at the beginning, and then waist going away when pressure goes up, and finally, I mean, you see the balloon with no waist, and the atrial flow regulator implanted. In this case, we decided to implant by using an over-the-wire approach, in case we wish to eventually enlarge by putting in a stent, but finally this was not needed, and the device was nicely in place, decompressing the left atrium and improving and functional class from 4 to 2 at 6 months follow-up. This patient had also a further study 6 months after implant, and because some increase of the gradient across the fenestration, we decided to stretch the device itself. This device was a 10 millimeter hole device, and we put a high pressure 12 Atlas balloon because we had some shrinking of the hole, which was probably under pressure from the septum. By doing this, we came back again to 10 millimeters, but probably it could be possible to overstretch a bit the hole by putting a stent inside. This is an interesting history of a 9-year-old boy with fontan fenestration by using a stent. The transeptal, let's say, was performed by using a broken bone needle and the radio frequency. This was quite hard as usually, I mean, to pass through a fontan conduit, but finally it was obtained, and several pre-dilations were performed until, and you see the very tight waist, until a stent was implanted with a dog bone technique. As you can see, it was interesting because it was possible to increase progressively the size of the fenestration by inflating step by step the balloon. At the end of the procedure, the stent was widely patent. You see how, I mean, the shunt across the stent. But what happened a few months after was that the stent the clinical conditions worsened again, and the stent was found thrombosed, and restenting in that case was performed. We decided to do that because it's a bit difficult to get the 4 and the 6 millimeter hole size of IFR in Italy, because it's still not, it does not have the CE mark yet, but it's going to have soon for PH. So if we need to use a 4 or 6, it's a bit difficult. And stent is preferred. But as you can see, and I don't know how is your experience, stents may thrombose early or later on. And the final case, which is even more interesting, 22-year-old boy with failure of fontan fenestration, PLE. He had the fontan, I mean, the step here was to perform a fontan fenestration. He had also, you can see a device already in place, an unplasted device, because this patient had a fenestration at the beginning of his history, and almost 8 years ago, it was decided to close this fenestration because some desaturation and the pressure did not change during the procedure, and the fenestration was closed. Few months after this done, the patient started to develop symptoms of failing fontan. We, as a first step, we improved the geometry by putting several stents in order to increase the size of the pulmonary arteries and of the conduit, but this did not help. It did help for 6 months, and then clinical condition worsened again, and fontan fenestration was proposed. This was quite tough, I mean, to perform the transeptal. Again, you see the Malin sheet, the broken bone needle, and some we were able to obtain some progression by attaching the broken bone needle to the cutter of the knife of the, I cannot find the word, but the knife which is used in the operating room, the electrical knife, let's say, and some progression was obtained, and then we did use perforation, coronary perforation guide wires to gain the access to the left atrium, let's say. And after that, it was not easy at all because we needed to perform multiple pre-dilations. This is the first pre-dilation with a coronary balloon, high pressure coronary balloon, but with a very tight waist. And finally, you can see a catheter coming down with a wire. This is a 300 centimeters coronary wire in order to create a circuit between the femoral vein, the femoral artery. And again, another high pressure balloon. This is a Mustang high pressure balloon. And finally, we were able to obtain some more room at 30 atmospheres. And then the left atrium, and then another high pressure balloon with the, you see the distance between the conduit and the left atrium. So we were passing through the space, and then 10 millimeter Atlas balloon to then implant an 8 millimeters arterial flow regulator. And then the final result. So clinical conditions improved significantly after this. The patient was in hospital for more than 2 months, and then it was discharged with the resolution of ascites and the possibility to move the diuretics from intravenous to oral, and was discharged home a couple of weeks after the procedure. What we did also during the same procedure, because of the difficulties in dealing with this patient, was, and here you see the fenestration with the wide open shunt from the conduit to the left atrium. During the same procedure, we did also something else. We implanted a Cardiomens device, which is a very nice device, which is used in other patients with heart failure to monitor pulmonary pressures. And we wish to do this in that patient because of the difficulties in a quite difficult clinical story. And you see the different steps. We needed to find a nice pulmonary artery, which was quite big, then a guide wire, V18, and then over the wire, the the Cardiomens is implanted. You can see how it is released and left in place. And it also was very useful, or helped a lot in dealing with the changes in treatment, in therapy, in drug therapy in this patient. And also we made our compensologists, let's say our colleagues dealing with the heart failure, more confident in what they were doing. And final slide on this initiative we have taken. We have sent around, we are going to send again a call for action. We have this arterial flow reducer registry in congenital heart disease. Till now we have had already positive answers from more than 10 centers worldwide with almost 50 patients. And we invite you to collaborate if you have any of these patients. Thank you for your attention.
Okay. Thank you very much, Dr. Butera, for your excellent talk. Αγαπητοί συνάδελφοι, θα ήθελα και εγώ με τη σειρά μου να ευχαριστήσω την Οργανωτική Επιτροπή για την τιμητική πρόσκληση να συμμετέχω στο Προεδρείο με εκλεκτούς συναδέλφους στην τελευταία συνεδρίαση του ξεκάθαρα επιτυχημένου συνεδρίου καρδιολογίας και καρδιοχειρουργικής συγγενών καρδιοπαθειών που οργανώνεται από το νοσοκομείο ΜΗΤΕΡΑ. Το θέμα της τελευταίας συνεδρίας με αρχή τον πρώτον ομιλητή θα παρουσιαστεί από εξαιρετικούς συναδέλφους που τυχαίνει να είναι και μέλη της Οργανωτικής και Επιστημονικής Επιτροπής. Συνεχίζουμε με τον δεύτερο ομιλητή που είναι ο κύριος Μητρόπουλος, διευθυντής της πρώτης καρδιοχειρουργικής κλινικής παιδών και συγγενών καρδιοπαθειών στο νοσοκομείο ΜΗΤΕΡΑ.
Αναρωτιέμαι μήπως πρέπει να αποδεσβέσουμε τον κύριο Μπουτέρα. Αν μου επιτρέπετε, κύριε Κουρτέση, τι λέτε? Μήπως έχουμε κάποια ερώτηση από το κοινό. Gianfranco, thank you so very much for your talk. We had a lot of interest on this subject, and obviously you are extremely experienced in this procedure. The device implantation of this sort started off for heart failure in adults, yes, and now it's being investigated for children with either left-sided obstructions and also pulmonary hypertension. So thank you for this introduction and your data. Could you please tell us how far we've gone with the use of this device?
I've not get your question. Since how far?
How many have you done yourself?
Okay. Yeah, I've done by myself 3 patients in 1 year. But we are, because it was a bit difficult to start with in Italy, some of them must be used under compassionate use scenario, which is quite long and complicated. In order to implant the device in the latter patient, we needed more than 2 months in order to get approval, with almost daily mails from myself and the hospital, etc. It's going to be a bit easier soon because the 8 and the 10 are already in the market, so I can ask for them and then use on off-label basis, let's say. And as soon as the 4 and 6 will be available for pulmonary hypertension use even in adults, that will be the same.
So do you have to get specific approval for the implantation?
I mean, if I need 4 or 6, which have not the CE mark yet, then I must have a formal approval from the Ministry of Health.
Okay.
Otherwise, I can discuss, have a chat in the NDT and discuss with the patient and take responsibility for doing an off-label implant.
Thank you. And Dimitri, how are things in the UK? What is your personal experience and what is the procedure for the implantation of those devices?
So, Freddie, thank you. Thank you for the excellent presentation, Gianfranco, as usually some really nice interventional slides. I would like to say with the Brexit situation that new devices have been very difficult to come by in the UK. You probably all know about that. And the regulatory bodies have changed and it has become much more difficult. So we're allowed to use a device, but it's very difficult to get from Europe. When we needed it, we couldn't get it, so we ended up doing the traditional stenting procedure with the restriction in the middle, as Oliver described it and Giovanni many years ago. Which brings me, so my experience is only with one patient implanting an 8mm device, and I have to say it was a very straightforward procedure. It's a very nice device. However, I have some questions from Gianfranco. It's a multi-level question, really. First of all, how would you convince the older generation, and I now put myself into the older generation group, unfortunately, of interventionists to move on from the traditional stenting procedures with the Diabolo configuration to moving towards a new device? What would you say is the great advantage of it compared to the old technique of the stents?
I see several advantages. First of all, I mean, I had the experience, direct experience, and also non-direct experience of stent thrombosis in patients with the Fontan procedure. Secondly, it could be harder to get into the stent afterwards in order to dilate the stent or gain more room into the stent, while it is really easy to pass through the hole in an atrial flow reducer. It looks also nicer and more elegant, and you know, for Italians this is a relevant topic too. But I mean, I think it stays on the septum, lie flat on the septum or on in the conduit, so it looks more kind of natural, let's say. So probably the cost will be higher, and finally also the label use will be a bit, I mean, more closer than putting a stent, biliary stent, for example, or peripheral stent into the heart.
The second question is, thank you. The second question, for the people that started using it, like myself, and not really have much experience of it, you have a multitude of lengths that you have to use. Do you have a strategy or a recommendation of the different pathologies, which is the right heart versus the left heart, of what device you go for as a standard? So let's say you have somebody with severe pulmonary hypertension symptomatic, would you go for such and such device? And on the left heart failure, would you go for that such and such device? For the Fontans, would you go for such device? Do you have any map in your head that you've created in the last 3 devices?
Thanks a lot again for this very relevant question. There are different sizes in terms also of septum thickness. As you have probably noticed in my slide, in the latter patient, we measured the distance between the flow into in the conduit and the exiting flow into the left atrium. So we finally used the device size or the device thickness that was appropriate. I do not have I do not have any experience in decompressing the left hearts in adults with acquired heart failure, let's say, or pulmonary hypertension. So I do not have much ideas about that. In congenital patients, we are building. I'm building my experience. So I usually get information from the patient itself in terms of the space between the two ends, between the two atrial, let's say, in order to decide from the lower thickness or the bigger thickness. In terms of size of the hole, let's say in smaller kids, I would use in Fontan patients like 6mm, while in bigger in adolescents and adults, I would go for 8 minimum or 10mm size. While when we need to decompress the left atrium, so I would go for a 10, as we did in this 16 years old patient with mitral stenosis.
Thank you. Which brings me to my next question after that. Sorry, but it is quite relevant. They're all linked. We only have, as you mentioned, a license to use the 8 and 10mm devices at the moment.
Yeah.
Do you see any concerns in using a bigger device for a smaller shunt? I've noticed that you predilate the atrial septum or the Fontan's fenestration, which you created, to create a diameter, and then you put the device in. To my experience, very limited, handling these devices, they're very soft. So could you use an 8 millimeter device to achieve a 5 millimeter defect on somebody with pulmonary hypertension to minimize the amount of desaturation? Or is that a no-no to your experience? Because that will expand the use of devices we have available.
Yeah, sure. That's again, always very interesting questions. And finally, our patient, our 16 years old patient, where we put a 10 millimeters device, then at follow-up, the hole became smaller, roughly 6-7 millimeters, and then we post-dilated again up to 12. Yeah, I think that it is possible to let's say oversize the device and get anyway a good hole. But probably I would not try to obtain a 4 millimeters hole from a 10. I would say that probably having a 5-6 from an 8, it's reasonable. And we tried before in one of these patients with in vitro, let's say, in different holes, 8 millimeters, and it was as well. I mean, it looked nice and flat, so even at 5 millimeters size. So it is possible to use a larger device to get a smaller hole.